time for. Thank you. I forgot. Darn. Corey's gonna fire me. If you have questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. Also, we will have time for discussion and questions at the end of the presentation. Please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. Today is our Let's Talk About OMM Research Journal Club. And the article is entitled The Role of Mental Imagery in Osteopathic Palpation with Julien Moreno.
Hi, everybody.
So Julien has been an osteopath in private practice since 2015, an OMM teacher since 2020, a pedagogical coordinator since 2022, and a clinical supervisor and dissertation director since 2022. He has authored the book 50 Exercises to Do Without an Osteopath, and is currently finishing a master's degree in research and education science. And he is visiting us from France.
I'm the French guy.
So please help us welcome Julien Moreno.
Thank you.
Okay, now I need to, first I need to share. We're in our new conference room and I'm just starting to get used to the setup in here, so.
Here we are.
Okay,
Okay.
there you go.
So, hi, everybody. I'm really happy to be here today and to present you this study and talking a little bit of palpation and mental imagery. It's a real pleasure because it's my first time in Kirksville, and I really want to thank Brian, Corey, and Jane for inviting me in this webinar in this journal club. So this study is a really interesting study because it's pretty recent and it's a European study. So I'm going to talk a little bit after about the differences shortly, but the differences between what's going on in the United States and what's going on in Europe, especially on the status of all the osteopaths. But this study, in my opinion, is really interesting because we are all concerned with palpation. Even though if we are not osteopath, even though if you're just physician, you are touching patients. But especially in this case, in the osteopathic palpation, we have to represent a lot of things in our head. Please forgive my English. I will do my best, I promise. This article was really interesting to me because it's a qualitative one. I'm really interested in qualitative research because it gave us a lot of insights of what's going on from a phenomenological perspective and from as we're going to see today, an interpretive perspective. So to understand what's going on when we are palpating patient in a complex way, because it's pretty complex, and all the implications that they're going to be in educational and practical perspective. And how palpation will affect our clinical reasoning, because it's one of the key elements, I think, in osteopathy, that we focus a lot on practice, but there is a lot of things that's going on in our head. Osteopathy and all the clinical reasoning is really an important thing, and palpation is maybe one of the link between both of these elements. And also, it's the emotional component, because emotions are always there, and how to manage them, and how it can be disturbing or helping during palpation, and during the assessment, and during the reasoning process and the decision-making process. So that's what we're going to talk today with this article. And I'm going to talk about the background. So in my opinion, the background is important, because what I'm going to show you, to explain, and to talk is maybe a reflection of where I live and what is the status of osteopathy in France, especially, because there is some cultural differences. As you know, maybe in France we are not physician. We can be only osteopaths, so only hands-on practice. We don't have especially medical practice. We almost exclusively practice in private practice. And the history of osteopathy in France is pretty special, because osteopathy arrived in France especially with physicians and physiotherapists, but it's been developed in a lot of ways. So that's the main difference. The other difference is the research. We don't have a big research lab like here in Kirksville, so research it's the beginning of the research in Europe, actually, in osteopathy, even though there are a lot of research on manual therapy, on communication and all those things, but especially in osteopathy, we're at the beginning, and there is a big emphasis actually on research. It's a pretty hot topic today, and I think it's a good thing, because it really challenges us, and on the way we see what we are doing, and to challenge our belief and our philosophy, if I can say this like this way. And this study and the background especially talks about palpation, and when we talk about palpation, we talk about touch, we talk about reliability, as we were talking this morning with Brian, and of course the goal is understand what we are doing and what is the key elements. So today it's in osteopathy especially is the somatic dysfunction. So we are going to if and how it can link all those elements together. So the purpose of this study is to determine the role of mental imagery for osteopaths and its benefits. So is it beneficial, or is it more disturbing? And we are going to see that there is a lot of elements with this study, but with other studies. Understand the implication of mental imagery in the decision process, and also the clinical reasoning, because clinical reasoning is not only decision process. There is a lot of aspects of clinical reasoning. Mental imagery, and the quality of touch, and how it can affect the relationship and its construction with the patient. And the methods used in this study, especially grounded theory, and how it can help to reveal unexpected data from the interviews. That's really interesting. I would like to begin with Andrew Taylor Steele, because I took this quote, but I could have put another quote, because he's talking a lot of how we see the body, how we use the vision, the observations, and this quote's just saying that I'm seeing first the bony framework and the joints, then I see the ligaments, and I'm also seeing in my mind's eye the nervous system. So Steele was already using mental imagery consciously, and it affects the way how we see the body and how he's going to touch and doing things with and on people, on his patients. So to be really precise, study objectives, this study is the study aimed to systematically determine what role mental imagery plays for osteopath, and especially what the benefits are when it is used spontaneously and deliberately. And as we are going to see, those final words, spontaneously and deliberately, are pretty important because sometimes it can be spontaneous but not deliberate, and it can lead to more disturbance than help. So for the introduction, it's really a key element of the professional identity and osteopathic training. Palpation is really a key element because we are using mostly our hands to touch and to treat patients. So it's a big part of our professional identity, and it's a real complex performance because touching and assessing and trying to make sense of what we are touching is a real complex cognitive, somesthetic, kinesthetic performance, and it's driven by top-down and bottom-up process that we are going to talk just a little bit, and it's pretty subjective. So to try to objective what's going on with palpation, it's really hard, and we were talking about that with Brian this morning. To be objective, you have to have some specific step to be and to let emerge the objective findings that you have with palpation. It's also multimodal sensory integration, and with practical experience, clinical experience, you can eventually, if you have the good steps and the good method, have more efficiency. Also, mental imagery may optimize palpation through training and practice. So I just put some studies there, but we know from research that consensus training may help for enhancing performance and enhancing also the reliability of palpation. And I think that's really something important to know, because if we want to improve our skills, if we want to improve our profession, we have to find some consensus, especially in science and research, to get something reliable at the end. It's a really big challenge, I know, but it's really important for the research. So I'm going to talk a little bit about the methods because it's pretty interesting. I like grounded theory because in that field of osteopathy, even though we know we have a lot of quantitative publication, knowing what's happening in the head of an osteopath gives us a lot of insights. And grounded theory can help us to build theories or add a lot more theories to an existing theory. So I'm going to just present that. So it's a qualitative quasi-clinical study based on a phenomenological paradigm, but more on the interpretive side, okay, not on the phenomenology purely side. So it's a really good systemic method to explore what's going on a specific subject. They use semi-directive interviewing with key question and follow-up question with, we can say, 3 phases. So first, pre-analyze. That's the pre-analyze that leads to then the categorize, how they categorize the different aspect of what they study, and after maybe some inferences. And the question is pretty social, so the result could help understanding the use and the implication of mental imagery in practice. We are going to see that in practice, but not only in practice, because there is a lot of elements in this study and in other studies. So the population, 9 experienced osteopaths. The inclusion criteria was at least 7 years of clinical practice and at least 5 years of teaching linked with palpation. The recruitment was made with theoretical saturation in 2 steps in this study. I'm going to show you how it was made after. So it's almost the same phase, but they repeat those 2 phases. So they select first a group of osteopaths, they made the interview, and they follow up with another phase to accumulate some data and to interpret some data. So one of the advantage of doing grounded theory, is that you get data and you analyze those data and you continue this process, and you can have this famous saturation of data that leads to a theory after. So it's pretty interesting, and we see that there is some, I don't want to say issue, but it maybe lacks some details, but I will discuss that a little bit later. So that's how they recruit the 9 osteopaths for the study. Therefore, they put the interview guideline. So it's a pretty standard interview guideline with the sort of warming, they call that warming up. So just explaining to the osteopath what they are going to do, about what they are going to talk. So to create a context, something decontracted, and to let the osteopath talk about what he wanted to talk. Then we have the main phase. So this is where the key question and the follow-up question are asked to the osteopath. And finally, the ending phase, the famous cool down. So it's like a synthesis or an ending conclusion of the interview. It helps also for self-reflection and for like a debriefing with the osteopath and see what was going on during the interview. So that was the framework they used for the interview. Then the data collection, it was a face-to-face recording interview with a recorder. And for the data processing, it was a manual retranscription with F5 software. And then they analyze it with Max, I don't know how to pronounce it, Max UDA software, for then the pre-analyze the categorization with the deductive and inductive process and the analyze. So it's really interesting with the method, and the result was also pretty specific, I found. So they find 5 big categories and 70 subcategories, with the 5 main categories: what function and benefits, situation, content of mental imagery, influencing factors, and significance and effectiveness. So in the first category, there was maybe two questions that they put forward. It was, what kind of object is this, and what is the function of this object? It was maybe the 2 key questions that osteopaths have in their heads. So they find that it helps for identification, recognition, and comparing, directing attention, navigation, orientation in space and in the anatomy, integration and learning. So what I have in my hand, is the real thing that mental imagery helps us to understand. So it helps to focus on specific area of the body and differentiate, make the difference between the body of the osteopath and the body of the patient, because sometimes it can be a little bit touchy, a little bit difficult. So mental imagery can help doing this. It may also facilitate the prognosis. So it's really interesting, the data they found. Also the situation. So for the situation, specific to certain body area and some conflict situation. So it helps also to understand how deep is the structure and how is it, what's the quality of the structure. And the conflict situation, it is the way how osteopaths are understanding the normality and the abnormality. So if there is an abnormality, what type of conflict is it? So that's what's running in the head of the osteopath. Also the content of imagery. So anatomical and physiological images. So that's what's happening, what we see in our head. For example, if you're touching PSIS, you are seeing PSIS in your head, your thumbs on the PSIS, comparing an imaginative picture. Sometimes it's not purely anatomical, sometimes it's a bit of anatomy and some colors or some other inputs that can be shared in this study, and individually perceived images, because not everybody are seeing the same thing in the same plan at the same moment for the same reason. So that's the part for the content of the imagery. There is also some influencing factors, visualization training. That's what I was talking about with consensus training. We are going to see that maybe consensus training may help for developing a real skill with palpation and mental imagery, how it can potentiate both of those factors. And there is also therapeutical attitude and procedure and individual differences in manifestation. So it depends a lot of the method of learning, because all method doesn't lead to the same results, and that's the thing. And the learning material, what was used to learn. For example, you can use anatomy atlases, you can use also interview, you can use a lot of things. So to optimize the process, paying attention to method of learning and also the tools is really important. And also they talk about this attitude, the therapeutical attitude. So the calmness really helps to focus on what we are seeing and what we can visualize in our heads. So the things that goes in the study is let the things comes to you, let the sensation comes to you, and don't process it too much. We were talking about that this morning because we were doing the model body test in the laboratory, and it was pretty interesting because almost everybody was saying, when I touch it, but when I'm thinking about it, is there an asymmetry or not? I cannot say if there is an asymmetry and which side is asymmetric. So don't process it too much, may be one of the key elements. So finally, the significance and effectiveness. It can be really supporting and accompanying, but it can be also disturbing and limiting. So this depends really on the experience and the way we use mental imagery. So if it's something that we let comes to us, it may indeed be something that is supporting, but if we process it maybe a little bit too much, it can be also disturbing. It depends also on the experience of the osteopath, not the clinical experience, but the experience with palpation and mental imagery. So it's linked to the training and the visualization training and therapeutical attitude. So that's the main result, and I find it really enlightened because we all doing this, and it puts some words on what we can feel and what we can imagine and how we can use mental imagery. So to continue with the discussion and the conclusion, mental imagery can be a real tool to support palpation and to potentiate it. It raises awareness on the cognitive performance of mental imagery, because it's even though I presented from a very simple way, there is a very complex process that can lead to the palpation and the way we see what we are palpating. And even though the way we see what we are palpating can change the way we feel it. So it's a really complex task, and I think it really needs a very good guidance to be mastered or to be introduced in the training. So the capacity as always can be improved with time and experience and training. And McConnell said in 1942, it is through coordination of brain and hand that natures of both the normal and the abnormal body are sensed. To continue, it can be also a disruptive factor. So disturbing the attention, disturbing the way we see the body if we maybe process it too much. And the tactic haptic accuracy may just be one factor of the palpation. So there is also a lot of factors that can influence palpation, like the body position or anything else. Sorry. So it can help also to trust what we feel and trust what we are touching, and how it can build the collaboration and the relationship between the osteopath and the patient. But they say maybe further research may be needed. And finally, this study cannot state the implication of mental imagery in decision making and clinical reasoning. But finally, if we just go back a little bit, clinical reasoning, as I said, is a big part. Decision making is one part of the clinical reasoning. So finally, clinical reasoning is what's happening in your head and all that can influence what's happening in your head. So even though they didn't explore especially clinical reasoning, we can see that mental imagery and palpation will influence from this point of view the way we think and the way we are going to analyze and interpret what we have under our hands. So it's part of the clinical reasoning, but they didn't explore it from a direct point of view. That was not the goal of the study. So I just put the final flow chart that is just, I don't know what's happening.
I don't know. Sorry, there was just a loud noise outside.
So if we took the mental imagery in osteopathic palpation, we can see that it can be used from a variable ways, and it can be used as a tool for identifying, for the recognition and the comparison with other, structure. And it can help to control attention and to navigate in the body and understand what we have under our hands. But on the other part, depending on the experience with mental imagery, the clinical experience, and the way we process information, it can be also a disruptive factor. So it can lead to distraction and be a disturbance for our diagnosis and all those things. We can see that different expert stages and different training system also can lead to those two factors. So using mental imagery as a tool or maybe a disruptive factor, and it has an experience. So they didn't know, but we can see that there is some implication, maybe with other research, but with the clinical and diagnostical reasoning, tactile haptic accuracy, and the patient-therapist relationship. So, according to the authors, there's some weakness in this study. So they said that the data coding was one of these weaknesses because it was done by a researcher alone, and the lack of research fund and personal resources. But there is also strength. The method, of course, grounded theory is not a very famous method in the osteopathic world, and I don't know in United States if the medical community know a lot of grounded theory because it's really used in social study. But it's pretty interesting. The recommendation follow-up and all the insight that gives the study. So clinical reasoning, decision-making, and in education. For the conclusion, the lack of research in the field of mental imagery and palpation, that's why they use grounded theory, was to calibrate and to let emerge one theory around mental imagery and palpation. It's just a piece of a larger puzzle. It was done like a pilot work, so that's why they use grounded theory. And it needs a further study to approach those complex processes. So I have my internal discussion and I want to share it with you. Therefore, we can discuss it later. There is other strength and weakness in this study. So as I said at the beginning, we are all concerned by palpation and maybe also with deliberate mental imagery. Maybe the sample size is a little bit not enough. Maybe some other interviews may be needed, but they said it, and further research may be needed. There's a really good level of abstraction and contextualization in the analyze with those 5 categories and all the details they gave. But the thing is that it applies maybe on this population, and that's another weakness that I find, that there is an insufficient population and recruitment description, because okay, we have the inclusion criteria, but we don't know a lot about the osteopaths that were interviewed. So the age, when they practice, which country. It's a German study, but are the osteopaths German? I don't really know. So that's what the weakness I wanted to point out. And it's really reflexive in the sense of it gives us insight on what we are doing and questioning ourselves when we are doing the things we are doing. So it's really interesting. There's some practical implication because we saw that the disturbance can be led by the conflict on the process running in our head and maybe the experience, not especially the clinical experience, but the experience we have when we palpate and we use mental imagery during palpation. So consensus training on this topic would be something really interesting to run for all the students, all the osteopath, not only the student, all the osteopath. And I wanted to talk a little bit about embodied cognition, because that's what's happening when you palpate. You have an idea and you palpate, you have insight, you have input, and depending on what you are thinking, on what you filter, on how your body is reacting, is positioning, you have other insights. So it's really complex, and it transforms the way you feel, because that's what's happening this morning. Students have the first impression, but then when they process, it changes literally the way they feel and the way they see. So maybe the first impression may be the right one. Personal experience with the mental imagery is maybe one of the how to say, maybe a good thing, because if you're used to do this, it's maybe easier to not evaluate, but to train after. But it needs a really solid framework and a really solid program to be really conceptualized and put it in practice. So I think we need a lot of pragmatism to not fall into some huge BS. So educational implication, that was that's what, sorry, I was talking about. So it may help a student to accept what they feel for the first time and not process too much. I think about what I said to my student, for example, when we are doing the first cranial course, depending on which theory and which model you are using. For example, if you put your hands on the skull and you are waiting to feel the CRI or anything else, it may be a little bit frustrating, and it's not even support with data. So I have just an example to give you of what I'm doing in these courses. It's the 1 second palpation. So I just said to the student, put your hands on the skull and just tell me if you feel it symmetric or not. And after, if you feel it symmetric, which side? And the second step is another 1 second palpation. is just you put your hand on the skull, you press it like you want to press a balloon, but with real pressure and not 5 grams, and just tell me how you feel the skull. And they run on different table, and they compare with other skull. And we made like a table to say, okay, how do you feel this skull? How do you feel this skull? Do you feel, and almost all students find the same symmetry and the same sensation. So when we put pressure and when we try to put some consensus training and some objective, how to say, a measure, you can have really something really reliable, and it gives confidence to the student. Also, it can build and integrate those data. It can help students to deal with clinical uncertainty, because that's what we are doing every day. Almost every day, it's clinical uncertainty. We have tools that help us to reduce clinical uncertainty, but I think one of the most valuable skills that we have as clinicians, not only osteopaths, but as clinicians, is dealing with clinical uncertainty with adaptability. So adaptability is really important in clinic. Also, the importance of practice, verbalization, and analogy to learn and appropriate knowledge. Because what we know with the data is that we cannot explain the same thing to everybody, because depending on the culture, on the way they understand things, the way they process, we need to use some analogy. For example, if I take the skull, maybe with some student, I will say, imagine it's just a balloon that you press. And with other students, I will say, imagine it's your bed, and you are going to just to touch, to test, to see if the bed is something really comfortable or not. So depending on what you are using. I take also the analogy that I put on this slide. So the highway, the twisty mountain road, or the dirt tracks. So sometimes it's an highway, and sometimes you have to take the twisty mountain roads to go there. So it depends on the analogy, but analogies are really important to learn. And finally, understand the implication of emotion in the process. For example, I have a pretty concrete example. When you are in clinic with a patient, if the patient and you doesn't find something that you can how to say, in the relationship, if there is not a really good relationship, you feel a little bit uncomfortable and you did not recognize what's happening into you, it can be a real obstacle of what you're feeling and what you're thinking, and can disturb all your clinical reasoning. So that's a thing to take in consideration. And I think, yeah, that's all. I put all the references and a little photo of steel. Thank you.
Excellent. Thank you. Me too. Okay. I'll try to put myself back on screen now.
That's the difficult part.
Yes. It's a brand new system.
That's
the first time we've used it. So there we are. Okay. All right. So thank you. Thank you.
Thank you for your attention.
So just a little bit about our opening up for our discussion. If you would like to speak during the discussion, please raise your emoji hand, which is located at the bottom of the screen under the reactions menu. We ask that you briefly introduce yourself, and please feel free to turn on your camera if you would like. When contributing to the discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. We will provide you with a timer to assist you in keeping track of time. After everyone has had the opportunity to make comments or ask questions, there may be additional time for comments or questions. The moderators will be happy to read questions or comments. If you would prefer to type them in the chat, please feel free to address each other's questions or comments there as well. And so we have had some comments. I'll start some questions in the chat already.
Yeah.
So the first one, there were 2 different people that asked for maybe some further explanation of what grounded theory is.
Yeah. So grounded theory is a method, a qualitative method. So usually when we build research, we made the state of the art before the research. This is when you know the topic. Okay, for example, I don't know, maybe on the pills, on the medication, on something you know that there is a lot of studies on this subject, and you want to go further. So you make the state of the art before. But in grounded theory, for example, when there is a topic that has never been studied, so you have small data or almost nothing, you have to maybe begin from the ground. So you are going to see the people and run some interview. And if you run a lot of interview, you will have a framework. And from that framework, you are going to categorize. So what are the main subjects with this topic? And after the main subject, what are the subcategories of this subject? So that's what they did. And grounded theory helps to theorize one topic. For example, this is the implication of mental imagery in the osteopathic palpation. So there is not a lot of data around that, and not a big theory. So this subject linked a lot of other theories, so educational theories, educational model, etc. So grounded theory helps to theorize this thing. So this it's like a pilot work. When you first a pilot work, or if there is also an existing theory, it can help to add different perspective to the existing theories. So that's what is grounded theory. There is a lot of way that you can use grounded theory, but it's the main one.
Okay, thank you. So Jed Downs has asked, the question I had when reading the article is, did the experts being interviewed come from a variety of training programs, or were they homogeneous in their undergraduate learning?
Yeah, that's the question I was asking myself also, because there is not a lot of description in the study, and that's one of the weakness, because it's a German study, so they didn't precise if it's all German osteopaths. We have only the inclusion criteria, but it's not sufficient in my opinion. So I don't know either.
Okay. All right. Angelique Mazzara asked a question that kind of to me sounds like a question to the whole group, not just you.
Okay.
She asks, how many DOs visualize normal anatomy as they treat?
Yeah, that's a good question. To talk about myself, I don't always visualize. I use visualization depending on the need. For example, if I'm with the patient and when I touch it first, I feel it pretty easy and I can find something really easily and quickly, I don't immediately use visualization. I use visualization when it's getting a bit harder with my hands, for example, but that's me. So
does anyone else want to comment on that? I see Jed has his hand raised. I think that's maybe about something else, but okay. So we'll come back to you, and if anyone else.
Can I
Yeah.
just make a comment real quick?
Please.
You know, one where that question comes from, often, you know, my teachers in cranial, they talk about visualizing normal anatomy. Once you found something, somatic dysfunction, you visualize normal anatomy. And what often is disruptive for me as I am on the experience train here is it gets disruptive because I'm seeing something that I'm characterizing to describe for the chart but that at the same time, I have to release that in order to feel the vital forces or feel a change, whether it's indirect or direct or whatever I'm using. So that's my, I'm sure we go back and forth. It can be just, I think you were talking about being disrupted thinking or visualization can be disruptive, but also very positive. So
Yeah,
that's my experience.
That's what I wanted to say. It's when you say visualize deliberately normal anatomy, but sometimes it can be really disruptive because you have something in your hand and you are trying to do something else with your head, and it's not, the things are not going in the same way. So that's the thing that's getting really disruptive. I think that's what you want to say about.
Right. And I think it's also trying to do something rather than allow the system to respond to your listening.
Yeah.
And I think that's the dance that I'm trying to learn. So.
Thank you. I will add, Rob Truax said in the comments, in the chat, I'm experimenting with visualizing the fluid edema leaving the areas under my hands. Okay. All right. Now it's Jed's turn. Jed has his hand up.
Oh, once a session. Yeah, I was just going to make a sort of an experiential comment with regards to learning, because I'm a late adult learner, and that is that when learning how to do mental visualization, it's really been useful when somebody has put their hands on my hands and said, "Okay, do you feel what you're feeling? And can you imagine that it's this?" And so I can begin to trust that, because I can feel what I'm feeling through my hands. What I have difficulty with is those individuals who have the skills to be able to sit back and look at me and say, "Okay, this is what you're feeling now, and this is what it is." And for some reason, that is not nearly as effective for me, because I'm always tied up in, how in the hell do you know that? And so I just thought I'd put that out there for all you people who are doing teaching, that the hand over hand for me has really been useful. The telling me what I'm feeling from a distance, just not so much.
Okay. That's what I call communication alignment with the patient. What I mean is that what I feel, I want to let the patient feel it also, even though I'm just visualizing it, or also because, as you said, if you feel it and you say, "Oh, there is this thing or this thing," and the patient, it doesn't make sense to him. If it doesn't make sense to him, it may be an obstacle for also the therapeutic alliance, but also the outcome, clinical outcome. So the way we communicate it, the way we arrange all those things together is really, really important, in my opinion. Not only in my opinion, data support this also, but I talk just about me currently.
Amy Dean has her hand up.
I was just wondering, along the lines of what Jen is saying, if there's like mental imagery of visualizing imagery versus like kinesthetic imagery, whereas like you hand over hand, where it's like, okay, I feel this fluid or bone here, feel this, like to a learner, and if there are different types of imagery, whether it's like a 3-dimensional versus a visual imagery, and I guess my bottom line question is like, how do we use this, or best use this, to teach others to feel things?
Yeah, I don't think I have a specific answer, because it will depend on a lot of factors, but it's a step-by-step process, because indeed, so it's really specific, because there's people that will visualize really specific anatomy, and there is a lot of other people that will visualize, for example, colors. I have a friend of mine that is osteopath in Vietnam, and his mental process is visualizing colors. So he doesn't visualize anatomy, but he visualizes colors or forms. So really, it depends on the osteopath. But yeah, indeed, the initial process may be anatomical mental imagery.
And does anyone else have any comments, discussions, questions?
Angelique, real quick, I do think in teaching basics, we really do need to be grounded in anatomy and to allow connectivity and start with the basics that we can feel, the joint motion mechanics, but because so often, and I'm seeing it in students that I'm teaching now, if you get too esoteric about feeling the energy of the fluids before they really connect with mobility and just limited range in certain areas, they just, oh gosh, this is too far out. I'm not this, they're losing confidence in training. So that's what my observation has been. And so, and there's quite a lot of variation now in the types of manual technique that is being used by various body workers, physicians, all kinds of different names, neuromodulation, and blah, 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 blah. So I can't, list all of the terms I'm sure you're aware of, but so my comments.
Yeah, totally. That's why depending on the model, what's important are the principles behind. Because when you understand principles, finally the model is not that important, because principle rules the model, and the model is just the expression of the principles. So like visualization, maybe indeed the anatomical visualization is the main road, but it's not the only one, depending on how your brain is functioning and what's convenient to you in your clinical practice, I think.
Thank you. I see we have a question from the ASO group, and this will have to be our last question. So, because
Right.
Julien and the rest to go back to their classes.
Yeah.
So, yes.
It's not a question, it's a comment that adds to the conversation. I don't
Excellent.
try to visualize normal anatomy. I do try to visualize normal physiology. And I think that's a critical distinction.
Yeah. So a dynamic version.
That's what I do.
Excellent. And I think that was Bill Brooks.
I agree. I hear the terminology well. Thank you.
Yep.
Bill. Hi, Bill.
All right, well, that's all the time we have for discussion today. Thank you so much. That was a fascinating article, and
thank you very much.
Don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, where, in the comments there and stuff, we can continue this discussion. Watch your email for an announcement when the recording is available. As a reminder, our Let's Talk About OMM research series will now be taking a summer break for June, July, and August. We've determined that everybody needs a break. So our next episode will be a network update with Dr. Brian Degenhardt and Corey Lubring on September 19th. So we will see you then. Thank you for joining us.
Thank you. Bye.